I think it started, sir.
Yes, sir, we are live, sir.
Can we start?
Yes,
Yes.
sir.
Okay. Good evening to all. This is Dr. Krishnaraju from Care Hospitals, Hyderabad. Now, this is a new initiative from Indian Academy of Echocardiography and Cardiac Imaging. So this will be on every month on third Wednesday from 8 p.m. to 9 p.m. on various topics. And the plan is to have 2 half-an-hour sessions, which means total time of 1 hour. So the speaker will have about roughly 20 minutes to speak and present, and the listeners can post their questions on YouTube, and we may have discussion for 10 minutes after the presentation. So this is going to deal with various topics for a period of time. I suppose it would include not only echocardiography, but other imaging techniques as well, like cardiac CT or MRI or PET CT or PET MRI, etc. So today we have 2 speakers. So Dr. Rishikesh Shah from Jupiter Hospital, Thane, Mumbai. And Dr. Shah is going to speak on stress echo in valvular heart disease. And the second speaker is Dr. Jasu Krupa from CMC Vellore. He would speak on cardiac amyloidosis. So both are very interesting and contemporary topics. So I hope that you will going to enjoy this presentation, and do ask questions if you want to on YouTube. And Dr. Manish Bansal is there to coordinate your questions, and the comments will flow after that. Dr. Shah, please go ahead with your presentation. You are not audible. You have muted yourself. Dr. Shah, you are not audible.
Okay. Now, can you hear me now?
Yeah, I can hear you. Yes.
Okay. Good evening, everybody. Today my topic is going to be on stress echo in valvular heart disease. So the basic premise from which this whole presentation is taken is from this ECAV and AAC guidelines, which was published in 2017 by Patrizio Lanciliotti and Patricia Pellica together on use of stress echocardiography non-ischemic heart disease. So we basically do stress echoes in 2 forms here in India. One is on the treadmill. Many people do on bicycle ergometer also, which is supine as well as standing both. So this is a chart of bicycle ergometer, which is supine, and there an incremental watts of load is added to the patient. While on treadmill, we do it on various protocols, Bruce, Norton, or modified Bruce. Then in few patients, we also do pharmacological stress, which is in form of dobutamine stress echo, where we give dobutamine. We start with 5, 10, 15, 20, and go up till 40 mics. And there again, we'll see the various different parameters of echo, and we monitor that throughout the test. So now let's go and dive into the specific topics for what we are. So severe AS. So whenever in severe AS, what we usually refer to as severe AS, whenever the jet velocity is more than 4 meters per second, mean gradient is more than 40 or 50, by ASC criteria it is 50, by American criteria it is 40, aortic wall area is less than 1, index aortic wall area is 0.6, and velocity ratio, that is DVI, has to be less than 0.25. Other than that, what is low flow, low gradient aortic stenosis? It basically consists of whenever you get an aortic wall area of less than 1, or aortic mean gradient of less than 30, or stroke volume of less than 35 ml per meter square, cardiac index of 3 liters minute per meter square, and transvalvular flow rate of 250 ml per second. Low flow, low gradient is further divided into with contractile reserve and without contractile reserve. which is true AS with contractile readout, and pseudo AS. Again, normal EF is again divided into paradoxical low flow, low gradient, normal EF, aortic stenosis, and with normal flow, normal EF, low gradient stenosis. So ideal hemodynamic conditions for aortic wall assessment is controlled hypertension, stroke volume of more than 35 ml per meter square, transvalvular flow rate of 250 ml per second. So this is 81 years old patient with history of LVF, past history of PCI. You can see his posterior wall is akinetic with BP of 170 by 80 with body surface area of 1.78 square centimeters. You see that aortic wall is highly calcific and it's restricted opening. There is bit amount of grade 1 AR and small amount of MR2. This is a short axis image showing infero-posterior wall, which is akinetic. And definitely this patient has a very depressed LV, which is very obvious with infero-posterior wall akinetic. And this is his flow across the aortic wall. And these are the parameters which we got on rest, where resting gradients were peak by mean was 43 by 27, stroke volume was 28 ml per meter square, that is index stroke volume. Aortic wall area was 0.73, while transvalvular flow rate was 186. Now, since this patient had a low flow gradient with transvalvular flow rate of 186 and stroke volume index of 28 ml, we decided to go ahead with dobutamine stressing. So this is basically a case of low flow, low gradient AS. So we started a dobutamine and 5 mics, and then we took LVOT flow, a CW or flow across the aortic wall, color Doppler, interrogation, and that we took in 5, 10, 15, 20. And these are the results. Now let us understand these results one by one. If you see the stroke volume, the resting stroke volume was 51, which increased to 65. So irrespective of whatever stenosis this patient had, his stroke volume has increased more than 20%. So he has definitely a cardiac reserve. Now this aortic wall area was 0.73, which increased to 0.82, which is still less than 0.1. So it is severe stenosis. But then at this area, what was the flow rate? The flow rate is 250. So this is an adequate flow rate, which we have achieved through dobutamine. So this patient and the aortic gradients from 43 by 27 went to 62 by 40. So this patient typically has true low flow, low gradient aortic stenosis, severe aortic stenosis with good contractile reserve. So this is true severe AS. Let's go to the next case. This is another patient with body surface area of 1.7, LVO2 diameter of 22, BP by 110 by centi. You can see there is a generalized hypokinesia of LV. The aortic wall looks heavily calcified. It's opening a bit, and this is the flow interrogation through it. And these are the peak images of dobutamine at 20. You can see that the LV is hyperdynamic than what we had seen at rest. And these were the images. These were the gradients, 42 by 24. Stroke volume index was 29 ml. Aortic wall was 0.78, and transvalvular flow rate was around 166. So again, we set to dobutamine, and this was 5, 10, 15, 20. And you can clearly see the aortic wall opening at rest and peak. In peak, you can see the aortic wall has opened quite a bit. And this was his the various parameters. The first thing which you see is stroke volume has increased from 50 to almost 70, which is almost good, more than 20%. So he has good cardiac reserve for sure. Aortic wall area has also jumped from 0.78 to 1.2. But this 1.2 has come at a flow rate of 345, which is way beyond 250. And the gradients were 55 by 32. So this patient has definitely got moderate AS or a pseudo-severe AS. Let's go to the third case. Again, this patient has generalized LV hypokinesia. You can see that. And then we took the routine parameters, and these are his findings of DAC. So you can see his resting gradients were 53 by 31, which increased to 78 by 44. Aortic wall area is 0.8, 0.9. His transvalvular flow rate was 256 ml. And his stroke volume from 74 to 82. So each stroke volume, except for stroke volume, all other parameters are fitting into severe AS. The stroke volume hasn't increased more than 20%. So he does not have normal or much of the cardiac reserve, but still he is true AS with little cardiac reserve. This is another patient with an area of around 20 mm of LVOT and 1.8 body surface area. Same generalized hypokinesia. And we went only up till 5 to 10 mics. And you see, just in 5 and 10 mics, we got a gradient which was 60 to 40, jumped to 110 by 7. The wall area reduced from 0.6 to 0.4 flow. So this was nothing but severe AS, and there was no doubt about it. So sometimes you don't have to go even to the higher flow rate, even if you can achieve it in 1 or 2 low doses of dobutamine. Third case, again, case of generalized hypokinesia with calcific aortic wall. Same thing, we did dobutamine, and these are the flow interrogation. So you see here, the first thing which you can see is the stroke volume. The stroke volume hasn't changed much. So there's definitely, irrespective of whatever the severity, there is no contractile reserve. The flow rate has increased from 167 to 259. So that's a good flow rate. The aortic wall area from 0.6 to 0.85, still less than 1. So that's severe. The gradients have jumped from 56.30 to 76.46. So this is true severe AS without any contractile reserve. So what is this contractile reserve? What is its importance? Whenever if the aortic stroke volume increased by 20% in a low flow, low gradient, that we call that the patient has contractile reserve. And usually no contractile reserve are usually the patients with afterload mismatch, inadequate increase of myocardial blood flow due to associated CAD, irreversible myocardial damage, either due to MI or myocardial fibrosis. So what we do, if in dobutamine, we don't achieve a flow rate of 250 ml. So what we do is, we actually extrapolate that information, whatever we achieved, and we calculate the aortic wall area at a flow rate of 250 ml. There is a special formula which you can see underneath here, which tells you about how to calculate the projected wall area for that flow rate of 250 ml. Let's see one example of this also. So this is a patient who is, you can see, generalized LV hypokinesia with dysynchronous septal motion, a case of LBBB, which you can obviously see there's a significant amount of dysynchrony there. And you can see a calcific aortic wall there, which is quite heavily calcific. And his resting gradients were this 52. Aortic wall area is 0.58, stroke volume was 30 ml, and transvagal flow rate was 156. So we went ahead and did a dobutamine with up to 20 mics. And you'll see this. His transvagal flow rates to start with was 156. It ended up only till 184. So we could never achieve 250 ml of transvagal flow rate. Although his aortic wall area was also low, and his stroke volume also reduced. And his gradients from 52 to 32 went to 61 to 37. So near it was touching a borderline of severe AS. Now the question here is, what would be the aortic wall area at a flow rate of 250? So what we have to do is, we have to project that. We have to put all these whatever calculated aortic wall areas and project the aortic wall area of 250 ml. And here it comes in between 0.7 to 0.8. So it is still less than 1. So this patient typically has severe AS with no contractile reserve. So in patients, when you don't achieve 250 ml of per second of flow rate, then you use this formula of projected aortic wall area. So let us quickly revise what we have understood in low flow. In which cases you do a low flow? When you get aortic wall area of less than 1, but the gradients, main gradients are less than 40, and LVEF of less than 40. Now, if the stroke volume increased by more than 20%, then you call it with contractile reserve. If the stroke volume do not increase, you call it with no contractile reserve. And if the stroke volume increased, but if the pressure increase, mean gradients increase by 40 and aortic wall area is less than 1.2, then you call it as true severe AS. If the mean gradient do not increase with dobutamine and EOA projected or calculated is more than 1.2, then you call it a pseudo severe or moderate AS. Patients with no flow reserve can even go up to the same criteria into true severe AS and pseudo severe AS. So no contractile reserve on DAC shows the perioperative mortality of 32%. But survivors have significant comparable improvements in LVEF and NYHA. Very high mortality on medical management. So what it basically tells us, if these type of patients without contractile reserve are able to survive the perioperative mortality, or somehow the perioperative procedure mortality, then they behave equally in the same way as people with contractile reserve. And people with contractile reserve have a bit of advantage in case of perioperative mortality. So now let's come to this. Is the aortic stenosis patient truly asymptomatic? Now, many times this problem comes, and why this I'll tell you. Because they have lot of comorbidities, obesity, it is a degenerative condition, COPD, OSA, hypertension, CKD, anemia, mitral valve calcification, skeletal muscle deconditioning, diabetes, coronary artery disease, hypothyroidism. Now, in all such patients, what to do? So, and many times the symptoms due to these comorbidities and with AS can also be mismatched. So it becomes at times difficult. And many people may not complain also, even if they have a severe AS. So in such patient, exercise testing in asymptomatic AS. So 1/3 of patient develop symptoms on exercise. Graded exercise test till 80% of target heart rate. Exercise test is terminated promptly at either THR, symptoms, hypotension, or arrhythmias. How do you call it as an abnormal response? If one of these is following, then we call it as a. So what are the things which you look for? Angina, dyspnea, dizziness, syncope, more than 2 millimeters ST segment depression, fall in systolic blood pressure of more than 20 mm of Hg, and ventricular arrhythmias, NSVT, or more than 3 VPBs in a row. Asymptomatic AS, positive echo, increase E by ratio, AS mean gradient of more than 20 mm of Hg, pulmonary artery systolic pressures of more than 60 mm of Hg, worsening LV, regional wall motion abnormality, reduced LV contractile reserve, LV GLS fall or increase of less than 1.4%, S-wave velocity of less than 5 centimeters per second, and peak VO2 of less than 84%, age and sex predicted. All these patients we considered as positive for exercise echo. So now let's go ahead for stress echo in MS. So let's start with the case. 50 years old woman presented with BSA with 1.8, no history of diabetic hypertension, asthma, came with PND, class 3 dyspnea, relieved with diuretics, unremarkable resting ECG. 2D echo showed mitral wall area of around 1.4 centimeters. So this is his. AML is doming in systole, PML is calcific. There is definitely restricted movements of the mitral valve. Here also you can see mitral valve opening is hardly there. And the calculated mitral valve area by planimetry came to around 1.4. His resting gradients was 14.2 to 6. So 14 by 6 were the gradients. And this patient was symptomatic. So we did it, his stress echo. And to our surprise, post-exercises gradient increased from 14 by 6 to 35 by 18, while his pH at resting was 30, 40 mm of Hg, which increased to 75 mm of Hg. So severe mitral stenosis, in which cases you do stress echo in mitral stenosis? So severe mitral stenosis cases where the mitral valve area is 1 or 1.2 and asymptomatic to bring out the symptoms, or patients with mild to moderate mitral valve area of around 1 or less than 2 with symptoms to bring them, and what is the reason for their symptoms, to produce them and objectively to quantify them, we do stress echoes. So it is class 1 indication if there is discrepancy between resting echo and symptoms, intermediate Doppler gradients and wall area. There is also efficacy of balloon mitral valvoplasty, you can test it. If the transmitral gradients double or mean mitral gradients are more than 50 mm of Hg or 18 on dobutamine stress echo, and pulmonary artery systolic pressure increases by 60, then these are the patients you have to go ahead and do a balloon valvoplasty or mitral valve replacement, whatever, depending upon the suitability of the valve. You have to intervene on that valve. Next case, 65 years lady, known case of hypertrophic obstructive cardiomyopathy and diabetes, has recently started complaining of dyspnea on exertion, class 2 to class 3. She had syncopal attacks on activity. During one of the witnessed syncopal attack in the hospital, the ROM had found her pulse missing. She was medically optimized on beta blockers and disopyramide in view of a recurrent pulseless syncope subjected to AICD implantation. However, her condition further worsened after AICD. Her syncope episodes increased in frequency, dyspnea progressed from new NYHA 3 to NYHA 4. Required frequent hospitalization twice with flash pulmonary edema and hypotension. Echo in all the admissions showed no increase in LVOT gradients and variable degrees of MR. Referred to us for explaining the mechanism of our pulseless syncope and flash pulmonary edema. Resting echo showed HCM, SAM with resting LVOT gradient of 30, grade 2 to 3 by 4 MR with grade 1 by 4 TR, and with the gradient of TR gradient of 35 mm of H. So this is the echo. You can see there is definitely a SAM. The septum is asymmetrical septal hypertrophy, and LV looks fairly good. And then this is an echo. You see there is some amount of MR. Now this MR, the pizza of this MR at rest, we got it around 9 mm. And then this is the TR jet velocity at rest, which was around 35. With the additional of IVC, it went to mild pH of 40. And then this patient, since patient was very symptomatic, we perform exercise in form of symptom-limited stress echo in the echo lab with patient still connected to ECG cable. After some time on treadmill, she developed VPPs and became ashen plain, breathless with mild sweating and non-palpable radial pulse. Treadmill was stopped and patient was scanned immediately. And this was the peak echo. And you can see there is a florid MR there. The MR which you had seen at rest has increased 3 to 4 times. Here also you can see whole of the LA is occupied by MR. There is hardly any blood flow going to the LVOT there. And this is one of the most important things. You see you are in mid-systole and still the mitral wall is widely open. You see AML and PML, they are not coapting at all. So their MR is wide open there. So this is a dynamic MR which was exercise induced. And a pH has jumped from 35 to 63 here. And the pizza from 9, it had went to 17 millimeters. You can see this. So post-exercise echo showed non-coaptation of mitral leaflets with more pronounced during seen in sinus and more pronounced during VPVs, causing free grade 4 by 4 MR, grade 2 by 4 TR with TR gradients of 65 and LVOT gradients of 35. The cause of a dyspnea was clearly related to mitral leaflet mechanics, exercise-induced acute free MR, and a rise in her LA pressures as reflected by acute rise in pH. The cause of a pulseless syncope was complete closure of LVOT, acute severe drop in LVOT flow and stroke volume, causing severe hypotension. Major LV stroke volume regurgitated into LA. Advised to undergo myectomy and mitral wall replacement. Post-myectomy and MVR, she came for follow-up with her. She was symptomatic, far more better. Her syncope had gone out of her life. Echo-wide patent LVOT, no gradient. Basal IV is adequately thinned by myectomy. Grade 1 by 4 TR. Normal functioning metallic prosthetic bileaflet prosthetic wall in mitral position. So this is it. You can see the mitral prosthesis. You can see the LVOT. Also, there is no gradient there. There's a bit amount of AR, that's it. But otherwise, no, the all SAM and everything is gone. And the TR jet is black to 26. And patient is fully asymptomatic now. So when do you do stress echo in primary mitral regurgitation? In primary mitral regurgitations, what are the points which you look for or bad prognostic match? Whenever an MR grade severity increase by more than 1 grade, like 2 MR becoming 3 or 3 MR becoming 4, that is a bad. Dynamic pH. Whenever a patient gets a pH on post-exercise stress echo and to begin with did not have or even had a mild pH, that is again a bad sign. Absence of LV contracted reserve, where LVF improvement is less than 5% or GLS is less than 2%, that is a bad prognostic marker. And limited RV contracted reserve with TAPSE of less than 18 millimeter post-exercise, remember this. So these are the parameters which tells you that this MR is definitely bad and need to be intervened. Now, when do you do stress echo in secondary MR? When MR is disproportional to the severity. Patient is complaining of dyspnea, but MR is hardly 2 or 3. Unexplained pulmonary edema in a case of MR. So you don't know whether this MR is causing the pulmonary edema or not. Intermediate severity of MR. So the patient says the patient has moderate MR or 2 by 4 MR and he is undergoing CABG. Now surgeon wants to know whether this MR needs to be repaired or can be left alone. And persistent pH after mitral wall repair. Now, stress echo in severe AR. Now, actually, frankly to speak, there is not much of stress echo in severe AR, but stress echo can be useful to reveal symptoms of severe AR who is asymptomatic or who lacks one of the following criteria for surgical AV. LVF less than 50%, LVIDD more than 50 mm, and LVIDD index of 25 mm per square. Out of this, anything is lacking or patient does not have symptoms and yet qualitatively and quantitatively you are getting a severe AR, you can go ahead and do a stress echo. Lack of contractile reserve, that is less than 5% increase in LVF, is known to predict LV systolic dysfunction development in both medically treated and surgically treated as well. So this is one bad prognostic parameters. But you have to understand this. As the length of diastole reduces with the value of stress echo, to qualitatively or quantitatively assess severity of AR by a stress echo is hampered. So it is not good to assess the severity of AR by doing a stress echo. It is only to bring out the symptoms of asymptomatic patients, you can go ahead and do it. And frankly, very, very frankly, there is very less amount of literature of stress echo in AR. Now a word about prosthetic wall. We can not just use stress echo for normal walls, we can also use stress echo for prosthetic walls. So if you get a prosthetic wall area or EOA of less than 1 centimeter square, an abnormal DVA of less than 0.35 in aortic or 2.2 in mitral wall, and low flow with stroke volume index of 35 ml, you do them low dose dobutamine. The same way you used to do a dobutamine in low flow, low gradient aortic stenosis. So same principles follow. If mean gradient in aortic increases by 20 mm of Hg or mean gradient of more than 10 mm in mitral and EOA reduced by more than 0.3 centimeters square, then we call it true significant dysfunction or PPM. Now, if stress EOA is less than normal EO, then it is dysfunction plus PPM. But if the stress EOA is equal to normal EOA, both are same, then it is isolated PPM or patient prosthetic mismatch. But if on low dose dobutamine, if EOA increased by 0.3, mean gradients is less than 10 for mitral and less than 20 for aortic, then this is pseudo dysfunction or PPM. And when you don't get any increase in stroke volume only, then there is no flow reserve and you cannot call it, or it is indeterminate. Fine. So before I conclude, I have a small appeal. The Echo India 2023 has been postponed to Echo India 2024 in March. The dates are 8th to 10th March, and it will be held in Mumbai in Westin Hotel. I would make this appeal and invite you, all of you, to join for Echo India 2024 in March. Please block your dates from 8 to 10 March 2024 and register on Echo India website. This will be all national and international luminaries will be there for this. I would request all of you to please register if you are not registered yet and make this gala event a successful one. Thank you. Thank you. Thank you.
Thank you very much, Dr. Shah, for your presentation and also for your kind invitation to attend the Echo India 2024 in Mumbai. Basically, I think we don't have too much of time to discuss because it's now approximately close to 30 minutes of your presentation.
Yeah. So
it was a good presentation.
So, sir,
and, yes, Manish.
Yeah, we have one question from one of the attendees. So we can, I believe, take that question and then move to the next presentation.
Okay, sir.
Yeah, sure.
Yeah.
My only comment here is,
yes, sir.
One, whenever there is a, clinical versus echocardiographic disparity, mismatch, then we go for this evaluation. And it's not required for every patient. We also use other imaging techniques. For example, we do an MRI. If the myocardium has a lot of gadolinium enhancement, then say something like more than 15% scar in the myocardium, they're unlikely to improve after aortic valve replacement. Second comment is the first case which Dr. Shah presented, low flow, low gradient aortic stenosis. in that situation, it is also important to look for as actively and rule out a cardiac amyloidosis, because that is one group where it is known that they may have a second problem, cardiac amyloidosis, and these people don't do well post either surgical AVR or TAVR. That is the second comment I would like to make. So now what's do you have any comment, Dr. Manish?
No, sir, no specific comment from my side, but as I mentioned, there is a question from one of the attendees, and he's asking, sir, during low dose dobutamine echo in low flow, low gradient AS, do we need to really achieve mean gradient above 40 along with AVA less than 1 square centimeter to call it as severe AS? ASC guidelines say that 30 to 40 millimeter mercury is sufficient to call it severe AS with dobutamine. So do we really need to achieve 40 millimeters mercury gradient, or 30 to 40 is sufficient? That's the question.
Dr. Shah, you have would you like to answer this?
Yeah. So there is no hard and fast. What is more important is whether you have achieved the flow rate of 250 ml per second. So transvalvular flow rate of 250 ml per second, and if you on that transvalvular flow rate, if you get an aortic wall area which is less than 1, that is more than sufficient to tell you, okay, this is definitely true severe AS you are dealing with. Now this 40 is or any number for that matter is very so like suppose some can get 39, another person can get 37 or 38. So I mean it is very, very arbitrarily, but yes, and what flow rate you are achieving, the wall area, that is more important. And if you get in wall area at 250 ml or more than that flow rate, if the wall area is less than 1, then definitely you're dealing with true AS or severe AS. You want to add something, sir?
Any other questions?
No, I think so. That's it.
No other questions?
Yes, sir.
Okay. So do you have a comment to make, Manish, from your side?
No, actually, I believe there will be other attendees who might pose questions during the course of the next presentation. So if there are any additional questions, we can take them at the end of the second presentation.
Yeah. Now, Dr. Shah, would you like, I mean, when would you choose treadmill versus dobutamine? And then two, did you have any, complications during the procedure, particularly treadmill?
Yes. So, sir, for low flow, low gradient aortic stenosis, is the dobutamine is the choice, definitely, because here you have a control of how can you go about by increasing the doses and then monitoring the flow volumes and everything. So low flow, low gradient, there is no doubt dobutamine is choice. Now for asymptomatic severe AS who are asymptomatic, to bring out their symptoms, you do it under supervision. You already know this patient has severe AS, but he is asymptomatic. So you wanted to increase his gradients, and in those people, you do it. But if you do it in the supervision and you carefully look at those red flags where there is ST depression or hypotension or arrhythmias or even a patient's symptoms, I suppose that is sufficient enough for you to stop, and you don't go beyond it. Now, as far as MR is concerned, and for MS, we don't do dobutamine for MS, but outside they have advised if you want to do dobutamine, then you have to take the gradients as more than 18, where the cutoff is 15 for exercise stress echo. For dobutamine, it is 18 mm of Hg for dobutamine for MS patients. MR, there is no point, they say, in doing an dobutamine. You do treadmill stress echo only for to look for. And for AR, there is practically not much of literature, as I'd already said, for to see how it helps in stressing.
See, the general understanding is that treadmill exercise is closer to more physiological setting
than
dobutamine, because the hemodynamic parameters which are impacted by treadmill are different from dobutamine. Right. So our own practice is, if the patient is capable of doing a treadmill, physically speaking, so no neurological problems, orthopedic problems, etc., we always prefer to do a treadmill exercise with echo rather than dobutamine with echo. So then the another question is, suppose if they don't achieve their heart rate, enough heart rate, do you use additional stress, or do you use something like atropine along with that?
So for low flow, low gradient aortic stenosis, you don't want the patient to increase the heart rate. So because you want to increase the stroke volume. When you increase the heart rate, the stroke volume subsequently will reduce, and thereby the gradients. So for low flow, low gradient, you don't want to increase it or something. Now for treadmill, whatever the patient at symptoms achieve the heart rate, that is sufficient. So we don't give any atropine or something. Yes, for ischemia, if you want, then we definitely would want to increase his heart rate, and then dobutamine for ischemia, we give atropine and we increase it up to 85 to 90% of the maximum heart rate. But for low dose and all those things, we don't require to actually increase the heart rate. We want the heart rate more or less to be as constant as possible.
Did you have any significant complications during these procedures?
No, sir. We do it routinely now, and we haven't come across any complication as such. Rather, this lady which we talked about of HOCM, we were expecting something, but as soon as the first symptoms developed, we stopped the treadmill, and we could, get all the parameters what we looked for. So we haven't come across any major complications as such.
When we are on stress echo, I would like to quote few of our patients, elderly women, particularly elderly women. You do everything looks normal. ECG, clinical examination, even resting echo, etc. Everything is perfectly normal, including the blood pressure. But they have exertional shortness of breath. So this is one particular condition where you do a stress echo, you will find a gradient developing in mid-ventricular alveoli. Exercise-induced intraventricular obstruction. So we put them on beta blocker, their symptoms just vanish. So this is something we have seen in about half a dozen elderly women. So if they can exercise, then we do that. So that is something which I wanted to add. Can we move on, Manish?
Yes, sir. I think, sir.
Okay.
Sure.
Is Dr. Jesu Kurpa ready?
Yes, sir.
Okay, doctor. Yeah. Now you are going to present, I see that on cardiac amyloidosis. Keep in mind that many of our listeners are not exactly practicing cardiologists. They may be general physicians or sonographers, etc. in Indian Academy of Echocardiography. So keep them also in mind to advise them what this is, when to suspect, what are the red flags when you need to suspect, and what to do about them. So we are very eager to listen to your presentation. Please go ahead.
Thank you, sir. Thanks for the invitation from IAE, and I'm happy to present on cardiac amyloidosis. It's a short presentation which involves just 2 cases. So when we say amyloidosis, what do we mean? It's an abnormal protein in short, which is produced either by the bone marrow through plasma cells, or it is produced by the liver. One is called transthyretin amyloidosis, that is this, and the other is called immunoglobulin light chain amyloidosis, or what we call as AL amyloidosis. So AL and ATTR amyloidosis. So it's an abnormal protein which gets deposited in the myocardium between the myocardial cells, and it causes wall thickening, and it impairs the function of the heart also. In this paper that came out a few years ago, what they showed was certain features or certain symptoms occur much earlier than actual cardiac disease. For instance, carpal tunnel syndrome, they found, predates cardiac amyloidosis by nearly 5 to 10 years. Now, what is the implication of that? Is the fact that by the time cardiac involvement happens, and many a time it's already quite late. So this is the awareness is growing. More and more cases are being diagnosed simply because we are talking more about it. There is more literature available. And we are keeping our eyes open also. So this is a slightly older case in 2019, a 57-year-old female who presented with heart failure, exertional dyspnea, class 3, PND for 3 months, pedal edema for 3 months, progressive fatigue, weight loss, loss of appetite. She was found outside to have a pericardial effusion while she was being evaluated for a thyroid nodule, for which pericardiocentesis done, and she was being followed on that track, the pericardial effusion track, and was investigated. Everything was negative for TB also. She also happens to be a diabetic for 5 years. She also has a history of a change in texture of the skin with difficulty in mouth opening for a year, dysphagia and hoarseness for about 6 months, paresthesias again for some time, and right knee pain and swelling. On examination, she had a pallor. She had this periorbital redness, what we call as raccoon eyes. I don't have a picture of her. Skin over the face was taut with reduced mouth opening, and she had quite a bit of hepatomegaly. And for the hoarseness, she underwent indirect laryngoscopy, which showed interarytenoid thickening also. She was in heart failure. X-ray shows cardiomegaly with pulmonary venous congestion. So much of what I'm going to present is found in a small booklet released by the Indian Academy of Echo and brought together by Pfizer, written by Dr. Nitin and Dr. Satish Govind. It's a hardcover small book. And I've followed the same format for the sake of simplicity. The case, however, is our case, but I've followed the same approach so that next time anyone looks at it, they will find it easier to relate to. So the first point that is mentioned is a mismatch between LV wall thickness and ECG voltage. So this is our patient's parasternal long axis view, which shows a thickened LV wall. There is pericardial effusion. The valves are thick, the mitral as well as the aortic valve. And the LV also has a granular sparkling appearance, which used to be given more weightage in the past, but not anymore because of ultrasound technology. And we know that even in normal people with harmonic imaging, we can have LVs or the heart looking quite bright. Also to note is the fact that this left atrial wall is quite thickened. This is the patient's ECG, which shows low voltage on the limb leads, a pseudo-infarction pattern that you can see in the anterior chest leads. And what we would normally expect is the thickness kind of goes hand in hand with the QRS voltage. But here there is a mismatch, wherein the more thick this gets, the smaller the QRS voltage happens. The second point is LV wall thickening that I've already mentioned, but it is put as a second point in this booklet with specific reference to relative wall thickness, what I've put here as RWT. Now, what is relative wall thickness? It is twice the posterior wall. That is, you can take the posterior wall and the interventricular septum. A surrogate of that is the posterior wall alone times 2. So posterior wall twice in relation to the left ventricular internal diameter or the cavity. So how thick is the ventricle in relation to the size of the ventricle? That is what we mean by relative wall thickness. So normally in normal hearts, we would find it less than 0.2. But in amyloid hearts, relative wall thickness is generally very high, more than 0.6, 0.8 also. So that is the second point. The third thing is that our patient has diastolic dysfunction. We know the algorithm. I'm not going to go into all that. But suffices that this one Doppler trace itself tells us that this patient has an advanced grade of diastolic dysfunction. Why do I say that? The E over A ratio is nearly 2, not 2. But there is also an L wave, which is fairly high in velocity, close to 50 centimeters per second, telling us that the LA pressures are high in our given patient. So LA pressures are high, there is diastolic dysfunction. The fourth point is that the tissue Doppler imaging of the septal mitral annulus shows very low tissue velocities. So this tissue velocity tells us about the longitudinal contraction of the left ventricular wall, and we are measuring it medially in the septum. So normal velocities would be 10 centimeters and above, definitely more than 7. But in amyloid, we have this rule of 5, wherein the S prime, this is the S prime in systole, and in early diastole, we get the E prime, and then late, we get the A prime. So S prime, E prime, A prime, all less than 5 centimeters per second. And the filling pressures are high, E over E prime, more than 15, much more than 15, it is 27. So that is the fourth point. Now the fifth point, this is just an illustrative picture from another of our patients with cardiac amyloidosis. In 2019, for this patient, we did not do LA strain. Having said that, left atrial reservoir strain, or LARS as we call it, is this, that is the peak left atrial strain. That value should be definitely more than 24% in normal individuals. Here it is just 6%. And if we had done it for our patient, it would have been even less. So that tells us that the left atrial reservoir function and everything else also is lesser than that. Tells us that there is marked left atrial dysfunction. And these patients can develop LA clots even in the presence of sinus rhythm. This is our patient. We can see that there is hardly any left atrial contraction, even by naked eye examination. The walls are very much thickened. This is the LG sequence of the 4-chamber view, and this is the long axis view, which shows marked late gadolinium enhancement seen in white here. The sixth point is right ventricular dysfunction. So amyloid is involving not only the left ventricle, but the right ventricle also. The right ventricle wall is thickened and it is dysfunctional also. The free wall strain is low. The TAPC is low. TAPC here is 1.4 centimeters or 14 millimeters. That is low. The RV free wall strain is -15. That is also low. Anything less than -18 or -20 would be abnormal. The right atrial pressures are high, IVC is dilated, and there is hardly any respiratory variation, as you can see here in the M mode. And there are diastolic flow reversals also noted, suggesting high right atrial pressures. This is another parameter which, again, is mentioned in this book and is there obviously from literature. It is not really, everybody talks about the apical sparing, but this is probably something also. It's the same thing, but expressed in a different way. Whereas in the interventricular septum, there is a basal strain which is lower than that of the apex. So there is a septal apical basal strain ratio, or SAB, that we call in short. A value greater than 3 is highly specific. In our case here, at the base, it is -8. At the apex, it is -16. And hence the value is 2. So that is also abnormal. Speckle tracking of the LV. There are different names. Cherry on top is one very popular name that is used. Or a better term would be relative apical sparing index, wherein the strain in the apical segments is taken as a proportion in relation to the average of the basal and the mid, the sum of the basal and the mid. A ratio greater than 1 suggests relative apical sparing, which has a sensitivity of 93% and a specificity of 82%. I'll come to in a moment why this specificity is low, though it may be highly sensitive. Another ratio that is used is a high LVEF to GLS ratio. In our patient, the ratio was 4.5. So LVEF 58.4, GLS was 12.9. The ratio was 4.5. So a ratio greater than 4 is also kind of a pointer towards cardiac amyloidosis. So you can have a normal EF, but a very low GLS. There is this increased wall thickness score that has been described by Bolrini et al. In echocardiographic diagnostic scores for cardiac amyloidosis in 2019. Essentially, it's a kind of repackaging or what we already know. There is an increased relative wall thickness given a score of 3. E over E prime is high, given a score of 1. TAPC is low, given a score of 2. GLS is also less than or in absolute terms more than minus 13%, given a score of 1. The septal to apical basal ratio is given a score of 3. So our patient has a total of 7. So the higher the score, the greater is the likelihood of the patient. The cardiac amyloidosis likelihood is much more. Having said that, this is not how all our patients present in real life. This is a classic case of amyloidosis, which in today's time, nobody may miss, or most people will be able to pick up. So as we are beginning to recognize more of this entity, we are also encountering more milder forms where these scores actually may not hold very strong. As you can see, only when it is greater than 8 does it say that cardiac amyloidosis is highly likely. That doesn't mean that a score of 2 cannot have amyloidosis. So this is a picture from a document. Again, the same thing, another name being relative regional strain ratio or relative. So here you have a picture where the wall is nicely thickened, as in our case, more than 2 centimeters, with relative apical sparing nicely seen, cherry on top. This is also cardiac amyloidosis, where the LV wall is mildly thickened. But what we need to appreciate is not just pattern recognition by looking at red and saying that it is fine, but to also within that look at the shades of red. And we can notice how markedly the basal strains are reduced in comparison to the apical strains. So even this is significant. If we were to use strict criteria, then we might call this as normal. We can enhance the diagnostic capability by adding biomarkers, and this is one such thing from a paper in 2020, which adds the sensitivity and specificity of our diagnostic tool using echo. I spoke about why sensitivity is a little low. That depends on the technique that we use. We need to make sure that the apex is not foreshortened. If we find that we have a foreshortened apex like this, and this part is nicely contracting, then in any patient, even in a hypertensive, we can get relative apical sparing. This I see in our high volume echo lab of where we do more than 300 cases, mostly done by sonographers. And when there's a tendency that, if you would detect one case with amyloidosis, then everything that follows, you are beginning to show a lot of relative apical sparing. So those are all false positives. There is a general, of course, there's a loss of longitudinal function. As we can see, there is no longitudinal function here. There is only radial function. And this is by the naked eye itself, you can see there is no longitudinal function. There is also a reduction of the circumferential strain, which can happen as the disease progresses. The circumferential strain value's base is around -8, and it's sort of preserved towards the apex, but the base is markedly reduced. Pericardial effusion I already mentioned, and that is seen as white in this cardiac MRI also. All other findings that I mentioned, the thickened walls, interatrial septum thickened, valves thickened, everything is nicely seen in this Cine SSFP image. Aortic valve is also thickened, interatrial septum is thickened, that has been shown here. We could show nice images of the pulmonary valve also on 3D transthoracic. Normally we cannot see the pulmonary valve so well. If we are able to take this so clearly, that means that the pulmonary valve is thickened. The tricuspid valve is also thickened, the mitral valve is also thickened. And there was a mild gradient also across the tricuspid valve. There is thickening as well as restriction. Now, echocardiographically, we can, apart from strain, we can also use the Doppler for prognosis. And in one slide, these are all different parameters which have been shown to provide incremental prognostic value, adverse prognostic value as compared to EF in our patient and in literature also. So advanced grade of diastolic dysfunction, pulmonary hypertension, a low stroke volume, as we have shown by this LVOT VTI. All these are adverse prognostic markers in a case of cardiac amyloidosis. Coming to the lab tests in our patient, the NT-proBNP was high, 4,500 plus. The free light chains lambda was elevated. That is the most common type, more than twice that of kappa. Is the frequency, of lambda restriction. Kappa restriction is found in only half the patients. And abdominal fat pad showed foci of amyloid deposits. So you can see lambda markedly elevated, and immunofixation showed only lambda. Normal values are given here for kappa lambda ratio, 0.26 to 1.65. Our ratio was 0.03. So studies have also shown that it is not only GLS. When we combine it with biomarkers, we can clearly see that when GLS is impaired, abnormal biomarkers, those patients do really badly. And this value in AL amyloidosis has been given as minus 14.8 as the cutoff. There are many scores. This is one such thing from the revised Mayo Clinic, which again is based on biomarkers. And the more these biomarkers are elevated, and the more the difference between kappa and lambda, like in our case, the worse is the survival. So just to summarize the algorithm of how we approach it. So clinically, we suspect cardiac amyloidosis. Our patient had all the various signs and symptoms. The first thing that we do is free light chains and immunofixation electrophoresis, which was positive in our case. We did a fat pad biopsy that also showed amyloid, and the diagnosis was AL amyloidosis. The systems that have been described in literature are there can be involvement of thyroid, larynx, GI, knee, skin, liver, neuropathy, renal. All of this was involved in our patient. This is the second patient, a 43-year-old male with weakness of lower limbs followed by upper limbs for 1 year. The nerve conduction studies showed a sensory motor axonal polyneuropathy. Everything else essentially was normal. Even the plasma cells in the bone marrow was not very significant. Immunofixation electrophoresis was negative. Free light chains, unlike in the previous case, was normal. Even a rectal biopsy did not show any amyloid deposits. The parasternal long axis view, again showing us thickened LV walls. The valves are not thickened. Minimal pericardial effusion. Again, there is relative apical sparing on the GLS. The GLS is also reduced. It's only around -11. This is the ECG, which again shows a pseudo-infarction pattern. But what we can see here is that the voltage is still preserved. So this is, again, something to note. And what we observe also that we find much thicker walls in patients with ATTR amyloidosis and preservation of the QRS voltage as compared to those with AL amyloidosis, which generally have a very rapid course, and it is almost like a cardiac emergency. We need to act very fast when we diagnose AL amyloidosis, whereas ATTR generally gives us some more time. It's more insidious in its progression. This is the technetium pyrophosphate scan that was done. And what we can see here in the planar imaging is this is grade 3 uptake. What is grade 3? Where the heart uptake is much more than that of the ribs. If it is equal to that of the ribs, that is grade 2. If it is less than that of the ribs, it is grade 1. So it's a very simple visual scoring system. The second thing is the heart to contralateral lung ratio. That is what we have shown here, the heart to contralateral lung. So the heart on the left side to the contralateral lung. And the ratio here is 1.89. Anything more than 1.5 is very significant. So our patient had a family history of similar complaints, that is a polyneuropathy. And it has been found that in familial amyloidotic polyneuropathy, there's a 50% association with such cardiomyopathy. There is also, of course, the wild type, which is found in older people, and they present with heart failure, HFpEF, and aortic stenosis, and other issues. So this patient, the immunofixation was normal, free light chains were normal, Bone scintigraphy was normal with bone avid tracers. The heart to contralateral ratio was greater than 2.5. It was a grade 3 uptake. This patient most likely had a genetic ATTR amyloidosis based on the family history itself. Just my last couple of slides. I've put a very simple slide. There are many, many things more, but I've just, for the sake of simplicity, I found the simplest slide available to kind of say what are the things that we should be looking for in day-to-day practice when we, which will make us suspect cardiac amyloidosis. This particular thing, especially if we find bilateral carpal tunnel syndrome or a spinal canal stenosis or a biceps tendon rupture, the Popeye sign. And this could go unrecognized, especially in exclusive orthopedic practice because of a lack of awareness. The other things may still get picked up. Neurologists, they may pick up, they may keep amyloid as a differential for chronic neuropathy. And that may happen, or an autonomic problem. All that is likely to get picked up faster. But this group we need to look out for. And of course, what comes to the cardiologist, either as AF or which we cannot explain, or some heart block, history of pacemaker, thick walls, these are all situations, conduction system abnormalities. Those are all things that will help us come to the diagnosis. Then, of course, the periorbital purpura, the raccoon eyes, and of course, vitreous opacities. Thank you all. So we need to be aware of clinical features and the various red flags. We need to know that it is not just one thing, any one thing. We need to look at the ECG, look for any kind of conduction disturbance, low voltage specifically. We need to look at imaging, which is echo, and if in some cases we may need cardiac MRI also. Nuclear imaging plays a huge role for ATTR amyloidosis. We don't need a biopsy in those cases. And biomarkers also play a huge role, especially the hematologists for their disease staging and myeloma and cardiac amyloidosis make use of biomarkers quite routinely. Thank you all. Thanks for the time.
Sir, you muted, sir. Sir, please. Sir, you need to unmute yourself, sir.
Shall we go on to the questions, or shall I make some comment?
Yes, sir, please, your comment, sir.
Okay. So the very first case of amyloidosis I had seen was in 1994. We made it out on transesophageal echo. That was my first case. But then we were analyzing our lab data, echo lab data. Then we found that, to our surprise, 20 years back, the commonest cause of restrictive cardiomyopathy was endomyocardial fibrosis, 20 years back. But now, last few years, maybe something like 8 years or so, number one is amyloidosis. Number two is primary restrictive cardiomyopathy. And EMF has practically, we don't see it much these days, maybe once in 2 or 3 years. So what I'm trying to say is, it is not all that unusual. Maybe we're missing many of these patients in the past. Now we are aware of that. So I think we request all our physician colleagues, sonographers, etc., to make note of the red flags which Dr. Krupa has highlighted, and keep your eyes open and look for that. The commonest misdiagnosis that has been made outside, when they come to us, we make this diagnosis. But outside, very frequently, the diagnosis is a hypertrophic cardiomyopathy. Okay, so I think whenever you think of hypertrophic cardiomyopathy, keep in your mind that the alternative right diagnosis could be either Fabry's disease or amyloidosis. So try to exclude them by your echo data. If necessary, go further and investigate them further. That is one message for you. Just making a few additions to what Dr. Krupa had presented. there is sometimes an isolated amyloidosis of the left atrium, only left atrium. Then two, the apical sparing is because there are no amyloid receptors in the LV apex. That is the reason why apex is spared. But this is not absolute 100% reliable, as it's been already highlighted. But it gives you a clue that it could be amyloidosis. Now we do quite a bit of nuclear studies. So technetium pyrophosphate, the bone uptake of the technetium pyrophosphate can give you an important addition to your diagnosis. In fact, some of the researchers have gone to the extent of saying technetium pyrophosphate positivity means that you don't have to do cardiac biopsy, endomyocardial biopsy. Endomyocardial biopsy was the gold standard all along. But now you don't have to necessarily do it if you are satisfied with the other criteria. And moreover, unless the right side is involved, your endomyocardial biopsy may not come out with any reliable data. And the fat aspiration biopsy is easy and low cost, though it's quite often is negative. You can also do a rectal or a salivary gland biopsy that also has been highlighted. Now the biomarkers, one comment on biomarkers, it is not diagnostic, but they are very important prognostic markers. They have been divided into type 1, type 2, type 3. Type 1 is both are normal. Troponin is normal. NT-proBNP is normal. Type 2 is one of them is elevated. Type 3 is both are elevated. So type 1, where none of them are elevated, the expected average lifespan is approximately more than 2 years, 2 to 3 years. Type 2, only when one of them is elevated, approximately 11 to 12 months. When both are elevated, it is less than 6 months. So it gives you some insight into prognosis, not necessarily into diagnosis. Then treatment has not been touched on much, but I don't know whether we have enough time. I might take a minute or two. So we now have, not long back, we had nothing to really offer to these patients. But now we have quite a few things which we can offer. You can treat their heart failure, but remember, digoxin is contraindicated because dystoxicity is very common in these people. And then beta blockers are contraindicated relatively. And also ACE inhibitors, ER blockers, they are also contraindicated. They can produce a very severe hypotension because they have autonomic disturbances because of the amyloidosis. ICD is another option we have when there is a life-threatening ventricular arrhythmias or one episode of ventricular tachycardia or beefing or repeated syncopes. We have an option of ICD. And we also have an option of liver transplant, particularly in ATTR. And we have an option of cardiac transplant in both AL and also ATTR. And new drugs are coming up for AL amyloidosis. We have cytotoxic drugs like melphalan, right? And also some analogs of melphalan. We have that. Now, the current treatment appears to be, this is being followed in some centers in United States, like in Boston, Mayo Clinic, some Canadian centers, is what they do is they take out the bone marrow stem cells and preserve them, cryopreserve them, and then give very high dose intravenous melphalan, because oral melphalan is not very effective. And after giving a 10 days gap, then they do a cardiac transplant. So with that, they seem to be achieving good results. And I have seen one patient from Mayo where they have just given only stem cells. And there was an excellent improvement of cardiac function. But whether it is repeatable, whether that will happen in every patient, in every center, I don't know. But they have shown an excellent result. So when you come to ATTR, one sentence about that. So ATTR is a hereditary basically, and non-hereditary ATTR is what is called as a wild ATTR amyloidosis. So now in these patients, you can use two types of drugs, like for example, TTR stabilizers, right? These stabilizers, they are small molecule inhibitors. So the small molecular inhibitors are good. And so famotidine, is in the market. So that is one of them that can be used, but it is very, very, very expensive. I don't think anybody can really afford except the top 1% in the Indian population, but it is available. And if somebody is sponsoring, maybe that is one good option. Then the new drugs which are coming are gene silencer. ATTR one category is genotyping. And once the genotyping is positive for ATTR, you could use gene silencers. So there is one gene silencer which has been studied by the American FDA, patisiran, and you also have vutrisiran. They are called gene silencers. So FDA has very recently refused permission for patisiran. So they advise the companies to go ahead with more studies and come out with data before it can be approved. And the ATTR also is benefited very well by liver transplant, because liver is the primary source of transthyretin, which is the one which is abnormal in ATTR cardiac amyloidosis. So we have plenty of options, but two things. One, you need to be aware of the presence of this in the community, and two, always aware that when you are doing an echocardiography, pick up those early red flags of the cardiac amyloidosis and then put it through the multidisciplinary team and see what can be done medically, surgically, or electronic devices like ICD or pacemaker, etc. So we have plenty of options. With that, I think we can take questions.
Yes, sir. So it was actually a very nice presentation. I'll make a small comment before we go to questions. As Dr. Jesukrupa mentioned, that not all patients present with this classical echo appearance of amyloid. Many patients will have subtle features, and we should be aware of amyloid being one of the possibilities, and we should not be missing these cases. Therefore, whenever we do echo and we find that the patient has got LVH, which is not explained, LV size is normal, and there is significant diastolic dysfunction, we should consider amyloidosis as one of the possibilities. Then look at all the other echo features, clinical features, ECG, to decide whether we are really dealing with amyloidosis. And if we suspect amyloidosis, then we have to go to one of these two routes. First is that we look at serum-free light chain assay and immunofixation electrophoresis to diagnose AL amyloidosis. And the other is we do bone scan to look for ATTR amyloidosis. So that is what is the basic overview of cardiac amyloidosis. The most important point is that we need to remain vigilant about this possibility and should not be missing these cases, which is actually very common. Subtle cases are missed quite often. And here NT-proBNP is also very helpful, which I have realized that in patients who've got normally upper left ventricle, which appears to be contracting normally, and we find significantly elevated NT-proBNP, then amyloidosis is one of the possibilities. So now we've got a few questions. So one question is that do all patients with suspected amyloidosis should undergo PYP scan? And second question also I will pose, that is, do we have to rule out cardiac amyloidosis features in all CKD patients who come for echo?
Yeah, I think others also I would invite to in the panel to also add on in case I miss out on something. So if it is the first question, if it is clearly, for instance, a patient coming from hematology which is bulk of our referrals. The question is, does this patient have systemic amyloidosis in a given patient with multiple myeloma? So there, the biochemical markers that I've already talked about, the free light chains, all that is elevated. There is a clinical condition that predisposes to this. In that, if we find features of cardiac amyloidosis, and the bone marrow also is able to demonstrate amyloid, there I don't think there is any additional value in doing an ATTR scan. Having said that, if for some reason we end up doing a technetium pyrophosphate scan, we should be aware that even in AL amyloidosis, grade 1 uptake is possible, or mild uptake is possible. And what in very rare cases, what is also possible is that you can have AL systemic amyloidosis, but you could have in a small, very tiny proportion, what you find in the heart may be ATTR. So that is exceptional. It has implications on treatment, because like Krishnam sir just mentioned, there are two different kinds of treatment. Having said that, for routine bulk of the majority of cases, if it is AL, we don't need to proceed. If these markers are negative, that's why that algorithm also has that kind of bifurcation. If those are negative, there is no systemic amyloidosis, then we kind of think about ATTR cardiac amyloidosis and a technetium pyrophosphate scan. And the second question is a difficult one, actually. And that is also not uncommon, especially when you are in a large discipline hospital. You get many such cases referred from EP. Every AF nowadays, and the patient may have diabetes, hypertension, other reasons for AF, and the question will be, is there cardiac amyloidosis? Many times it's very hard, unless it's very obvious, thickened walls and all the features that we talked about. It's kind of hard to, LS strain can be reduced due to many other reasons. And CKD also the same thing. You can have LV wall thickening and that bright appearance. All that is possible due to CKD and hypertension and diabetes itself. There, especially if we find low voltage and there are no risk factors, the kidney size on ultrasound is normal or enlarged. It is not a shrunken kidney. If we take all those things, then I think by echo the confidence is higher. That is what that is my opinion. Others can add. I would invite Dr. Manish and others also to add on here.
I think I would like to just make one point that renal involvement is quite uncommon in ATTR amyloidosis, unlike the AL variety. So in a patient who has renal dysfunction, we suspect cardiac amyloidosis on the basis of echo, and there is no feature suggestive of any plasma cell dyscrasia, then we can assume that the echo findings are likely to be because of CKD and not ATTR amyloidosis. Mild degree of renal dysfunction can occur in any form of amyloidosis, but advanced renal dysfunction is quite uncommon.
So one comment is there is something what is called as secondary amyloidosis. You know, not the three types we talked about, AL, ATTR, and wild types. But there is also what is called as a secondary amyloidosis, also known as senile amyloidosis. Okay. Now, it can involve the kidneys quite significantly, but not the heart. So it is very unusual for senile amyloidosis to involve the heart. So the CKD, what is the etiology of the CKD also plays a role. Second comment I want to make is, clinically speaking, there are two things which sometimes can give clues to whether it is AL or ATTR. One is macroglossia. Most of us don't even look at the tongue. We used to do it as long back, but now we are not looking at the tongue at all. When we wanted to look for anemia, we used to look at the tongue, or for cyanosis, look at the tongue 20, 30 years back. But now we are not looking at the tongue at all. Actually, we are not looking at the patient most of the time. these days. That's the complaint I have from many of our patients. So if there is macroglassia, which is much, much more common with AL than ATTR. Second thing is periorbital purpura. Periorbital purpura may be the presenting symptom from the patient. This is again far more common with AL amyloidosis than ATTR. So that is another thing which will help us. But I think the most important comment I would like to make is keep the diagnosis and possibility of amyloidosis in your top compartment. Whenever you are doing an echo in a patient, particularly with left ventricular hypertrophy, and you have no reason to think that this is due to either hypertension or hypertrophic cardiomyopathy, etc. So the awareness that this is a real clinical entity and something can be done with the current technologies for diagnosis and confirmation, and also treatment-wise, medically and surgically. So we need to be much, much more aware of that. So these are the few things which I would like to make. I think our seminar or discussion would have been successful. I would consider it successful if our listeners go back thinking that, yes, we need to have the diagnosis of amyloidosis in our mind whenever we look at this thickened myocardium. If they can have that in their mind, I think we have done the purpose. Second, the last comment is, there is a curious mix of cases where, very rare, both can coexist, ATTR and also AL. So it confuses the thing much more. But fortunately for us, we have patients who have both of them together, the same patient at the same time, are not that common. So less than 2 or 1% in various studies, but that is another possibility. So that complicates our treatment strategies because it is very important to know what is the subtype of amyloidosis the patient has. The reason why it is extremely important to know the subtype is the treatment pathways are entirely different. So I'm not happy with making only a diagnosis of cardiac amyloidosis, but I would like to go forward and split it up into what is the subtype. So once I know the subtype, I know what can be done for the patient and what is the likely prognosis, because AL is far more malignant than ATTR. I'm done.
So we don't have any more questions, sir.
I think we are 9:20 now.
Yeah.
Do you think we can close with
I think
thanks
so, sir.
to the presenters and the listeners?
Yes, sir, definitely, sir. It was a very good session. Both the presentations were excellent, and I believe our listeners benefited from these sessions, these presentations, and this video will be available on IAE YouTube channel. So those who have missed the session today will be able to watch it later also. And then we will look forward to them joining for the next session next month, third Wednesday, 8 to 9 p.m. And I would also want to mention here that the IAE members and other audience, they can, if they want any specific topic to be covered, they can write to IAE office, and we would definitely like to cover those topics which are of interest to most of the attendees here. So,
can I make one suggestion?
Yes, sir.
The suggestion is, even after this seminar presentation, 2 discussions, very good and very contemporary discussions we had, maybe some people want to put up questions. Can they do it through some web channel of our IAE?
Yes, sir. They can write to IAE office. They can visit IAE website. Or I can mention the email address here: office@iaeeco.in or secretariat@iaeeco.in. They can use any of these 2 email addresses for their queries, and we will reply to their questions.
Also, the YouTube channel, there is a comment section below where they can post their question for a particular topic also. So that also that will be answered.
Yeah, any question, any comments posted later will also be addressed.
Okay, that should be good. So thank you very much, Dr. Bansal, and then the presenters, Dr. Shah and Dr. Jayashree Krupa, for their kind presentation, which was very enlightening to all of us. And we thank the audience for their time, and we'll encourage them to rope in more listeners in their circles, in their institutions, and then also be active on the YouTube channel by posting their questions. So that would be very nice, because the questions will make us think about it and answer appropriately. So we also get educated about more and more about these topics. Thanks, everybody, and good night to everybody.
Good night, everyone.
Good night. Thank you.
Thank you.